I am pleased to welcome all of you to the Regulatory Ethics Knowledge and Support Modules 2021 Summer Series on clinical trials. And today's webinar is a pathway to decentralized clinical trials as part of our summer series. So I have a few housekeeping items for us today. My name is Sarah Vitone. I'm a bioethicist with the GUTS program here at Georgetown Howard University's Center for Clinical and Translational Trials. The GUTS program is a multi-institutional consortium of medical research institutions, and the members, as I mentioned, Georgetown Howard, MedStar Health Research Institute, Oak Ridge National Labs, and the Washington Veterans Affairs Medical Center. Through multiple partnerships and collaborations among these institutions, GUTS is transforming clinical research and translational science in order to bring new scientific advances to healthcare. We've been working at this for 10 years together, and one of the primary goals that GUTS has is to improve infrastructure and supporting high quality multidisciplinary clinical and translational research. We also continue to develop a model of interinstitutional collaboration. We design and implement research that will have high impact on underserved populations. We design and disseminate vibrant and innovative educational programs like this one. And we draw from and contribute to the collective effort of the National CTSA Consortium. The REKS module that we're representing today is Regulatory Ethics, Knowledge, and Support, and our component emphasizes promoting and preserving the integrity of research, the researcher, and the research enterprise, preserving the trust between the public and the research enterprise and the public trust in the fruits of the research process. And today I am pleased to welcome Dr. Nichelle Cobb. She is the Director of Operations and Senior Advisor for Strategic Initiatives. Dr. Cobb is as I said, the Senior Advisor for Strategic Initiatives at the Association for the Accreditation of Human Research Protection Programs and the Director of Operations for SMART IRB. And prior to this, Dr. Cobb was the Human Subjects Protection Officer for the Institute of Clinical and Translational Research at the University of Wisconsin-Madison. Since 2007, she has been involved in the formation of several statewide and regional IRB consortia. Her SMART IRB work involves developing resources and providing educational materials to help institutions transition to single IRB review. In addition, Dr. Cobb serves as a member of the SMART IRB Harmonization Steering Committee and participates in working groups that develop harmonized approaches for key human subjects issues. Dr. Cobb was also an AHRPP member, council member, and site visitor. So today's session, Decentralized Clinical Trials, Key IRB and Regulatory Considerations, is guided by, the idea that COVID-19 has accelerated a trend already in process and increased in decentralized trials. Decentralized trials generally involve study procedures that are conducted remotely, such as participant recruitment, informed consent, data collection, and safety monitoring. The shift to remote study procedures poses unique challenges. This session will provide an overview of the regulatory issues that decentralized trials can present, including IRB review and what investigators should be aware of when planning such research. Dr. Cobb, I am pleased to welcome you today, and you have the floor. Oh, sorry. I just want to remind the participants, if you have questions, please post them in the chat. There will be a Q&A after the end of the presentation. We will also have an evaluation form for all of you, so I appreciate you staying alert to the chat. Dr. Cobb.
Thank you so much for that very kind introduction. It's an honor to be here. And even though I am no longer with the University of Wisconsin-Madison, I had great affection for CTSAs and investigator-initiated research. And even though a lot of my work has recently concentrated on single IRB, I have had the privilege of really helping think through some issues related to decentralized trials. And in fact, one of the things that struck me is decentralized trials is kind of a funny word or phrasing of that, because it doesn't really sound to us a lot like what it really is in some ways, although I understand where the term came from. So I hope to share really from the perspective, as Sarah mentioned, from regulatory issues and how you might address them. And I know you've got this whole wonderful series you're going to be part of. And so I will give kind of, I hope, a framework that will help the rest of it, give it some background that will help tie it back to the regulations. So if you wouldn't mind, next slide. So I'm going to talk about these issues related to decentralized trials, and especially the IRB review issues. And we should have plenty of time for discussion. Next slide, please. So as I said, like when I first started thinking about these things, these happen without there being an official label in some ways, but this happened, the idea of a decentralized trial, way before COVID. And I'll explain a little more about why these came into being, but there is actually work that was done by a group called this Clinical Trials Transformation Initiative, and it's a kind of a government public-private partnership out of Duke University. And they did a really nice paper that I included in the resources that about what these are, why they're important, and what are some of the issues that we need to work to solve to make these happen more easily. And the idea behind them is that there are procedures that are just not happening in the traditional way that we do clinical trials, which is usually you recruit participants, you bring them into a site, you do all the procedures, either the eligibility might be done over the phone a little bit, but there's some lab tests that you do on site, you give a drug on site, you have them come back and monitor them on site. So usually there's a lot of traveling of participants to come into the clinical site. And you can imagine that for some people that could work okay, and for other people, it was really quite a burden to bring them in. So this can mean decentralized trial that it is everything is remote or only some of that. So if you wouldn't mind advancing, because I think I have the arrow on the slide. And so you'll hear these by various names, and virtual trials is one that really resonates with me a little more. But I've also heard the use of home trials or remote trials, and home trials because there are trials that are increasingly using going to the participants' homes to do the actual study procedures. And many researchers have been doing this for a while, but they didn't have this particular label. But for the clinical trials involving investigational drugs and devices, this is a newer area that's being explored. So next slide. So as I said, they could be to qualify as a so-called decentralized trial, virtual trial, or you might have no physical visits to the traditional study site, or a limited number, like you may have reduced the number and do a lot of things that are in the person's home or have them go locally as opposed to coming back to the study site. This often involves these decentralized trials, telemedicine, or visits, or even the use of mobile or local healthcare providers. So a lot of home health employees may have been leveraged for going and doing the actual taking vital signs or doing blood draws and doing other procedures within the participant's home or closer to where the participant lives. And increasingly, we're seeing that there's use of devices and other technologies to actually collect data remotely from participants, like Fitbits are being used to collect certain information, and other things are being developed specifically so that you can actually get data and from the participant, something as a wearable device or some other technique, and transmit that data to the clinical site or to the researchers. So it's a really interesting that decentralized trials, as you can see, can mean a variety of things, but at least has some element of a remote, virtual, or not the traditional coming in for every single visit to the traditional clinical site. Next slide, please. So this is just to reinforce this a little bit. But the other things you can see is that if you start going to participants or having participants do things like collect their own data, then you're going to have to adapt other parts of the classic clinical trial. And so you will often see with these decentralized clinical trials, and again, with COVID, a lot of this was done without the label of decentralized trial. It was because we had to do it because of the pandemic conditions. So more and more researchers are leveraging the remote informed consent process, trying to figure out how to recruit people remotely without bringing them into on site to assess eligibility. Doing the telemedicine, as I mentioned, to either as part of the eligibility establishment or as part of the study visits. Home healthcare personnel I've mentioned, but the other things that I've seen happening is that mailing kits to collect samples where participants can do vocal swabs, or they can do other collection of biospecimens to provide and send them off. Giving people devices or sending them devices where they can collect their own information, or even using their own devices that they might have, like a smartphone, and having apps that they download to collect information. And lastly on the slide, but certainly importantly, is you can imagine that, okay, if we're going to have people do things that have some risk and we aren't seeing them all the time, how do we make sure they're safe? How do we make sure our data that we're collecting actually are high quality data? So there's more and more, and you'll see these, that there are professional services being offered, but more and more organizations, CTSA institutions, are providing and getting really adept at remote trial monitoring. So both to make sure that there's compliance with the study protocol, but also the monitoring that you might need to do to make sure that the research participants are as safe as they would be if on an on-site clinical trial. Next slide. So why are we doing these? Why is decentralized trials a thing? And to a certain extent, it's because of the expectation that these may be less expensive than the traditional clinical trial of having people come in, reimbursing them for travel. That is one of the things I think that components of a decentralized trial that remains to be seen, because I think there could be trade-offs in cost. But I think more importantly, and especially in this time where we're really all the work, and especially the work CTSAs are doing to decrease health disparities and increase health equity and be mindful about inclusion and diversity of trials, decentralized trials may be the way to go, because you can imagine the barriers that many folks face in trying to get to time off from work or daycare or other things that may not allow them to travel or travel as much to a site that's far away. In Wisconsin, where I live, we have a great interest in rural health. And so this is one of the ways that we have been thinking about how to include people in trials that normally cannot do that traveling down to Madison, Wisconsin, that's 3 or 4 hours away multiple times to undergo a study treatment or participate in a research study. So it's really something that there's still, the data will show us, but there is a sense that this will not only increase accrual, but increase retention and actually increase engagement in a research study. There's other things that can be designed, and that if you get somebody involved and trained to use different technologies, that you can, some people really get into those trials because they really, it's so easy for them to participate and collect certain data, like wearing a Fitbit. You don't really have to think too much about collecting data. It gets transmitted. You just have to remember to put it on. But there's other things with smartphones that lots of us carry around everywhere. There are ways of pushing surveys to say, how are you doing today? Do you have these symptoms? So you can see how these things can be leveraged to ensure safety and engagement as well. Next slide. So these sound wonderful, and I think they are. I think it really is exciting to rethink how we've done traditional clinical trials. And I think CTSAs are really a place where you have been doing some really creative thinking about biomedical and clinical research. But one of the things that has not entirely kept up is that there's still things that we need to think about that are regulatory in nature related to clinical research or human subjects research in general, but especially clinical research. And the three that I will really touch on in a little more detail is what you need to think about if you're using telemedicine or mobile health procedures. The fun thing, if you want to ship drugs, especially if they're not FDA approved drugs, How do you do that? How do you dispense them? I should include devices there as well. How do you get devices? There's devices that are being tested by the study versus devices used to collect information from research participants. And of course, our favorite, and of course, something near and dear to my heart, IRB issues, which also can touch upon single IRB, which I will note a little bit when talking about IRB issues. So next slide. Telehealth and mobile health procedures. So this is what we call the fun of state law. This is not as much federal regulations, although those have some impingement. And a lot has changed about telehealth as a result of COVID, which there was a lot of loosening up, and we'll see if those requirements remain in place. But one of the things to think about if you're doing a multi-site study, but even if you're not doing a multi-site study, especially if you draw participants, patients who are potential research participants who live out of the state that you're in, you have to think about, are you licensed to practice in that other state? And this would be true whether for research or not. And there's some compacts certainly between states, and there's some arrangements. But this is one of the things that if you, for any telehealth visit, whether or not you're conducting research procedures that are clinically based or otherwise, you'll have to determine, like, you may need to hold a license in the state where you're practicing medicine, which may mean if somebody is in Maryland and Virginia, you may need to have somebody who's licensed in both states if you are drawing participants from there. And some of these multi-site trials are really far flung and across the United States. So there are some of these that are industry sponsored that really they have to get people in all 50 states or a large number of the states. So it's something that to think about is who needs to be licensed where and for what states. And that's something to think about, not only in the traditional clinical trials, somebody who might have lived in Virginia might have traveled to DC or Maryland to see somebody who it was clear that they were licensed where they were seeing the patients, but this is something that you'll have to determine, who is, and hedge your bet sometimes about where somebody will be. The other thing is about not just the telehealth, but about whether you can prescribe a drug for somebody, and then we'll talk about the shipping of the drug. So those are just a couple of things to think about in terms of state law. And what this is where you'll see, and I'll mention it again, where having a good relationship with a legal counsel is a good idea, that a lot of organizations are working this through on behalf of all the researchers. But if you may sometimes be the first one, and may need to talk to a legal counsel at your organization just to say, am I covered on this? So next slide, please. Mobile healthcare providers. So these are what I'm thinking of here is people who actually can go into somebody's home to actually do procedures. And sometimes these are home health individuals, traveling nurses, or other examples. So these individuals are not necessarily members of the study team or not hired by the organization conducting the research. So it may be a contractual relationship that you have with these individuals to help out with the research study. So you can imagine that in these cases that one, you need to make sure these individuals know what the research protocol is. They may need training, and most organizations would say these are equivalent to study team members, so they need to know good clinical practice. So they might know clinical care very well, but we also want them to know, if they're collecting data, to how to comply with good clinical practice. Probably also want them to have taken some human subjects protection training, training perhaps about data protection and biospecimen storage. So these are the kinds of things that you think through, that if you are working with people on a contractual basis, are they really members of your research team, and what other training would an IRB or would be not just an IRB expecting, but would be prudent for them to undergo. And also being very clear about, just like you would do if you're a principal investigator, of delegating tasks, making sure that that is accounted for in your documentation. So one of the things I'll talk about later with IRB is about this concept of whether somebody's engaged in human subjects research. So there's a lot of discussion whether these individuals are providing a professional service and therefore not engaged, or there are going to be times where they are administering a study intervention and therefore are considered engaged and not providing a professional service, and therefore there's a lot of other things that they have to do. So you can imagine how do you know who will be part of, if you're working with an agency, how do you make sure that whoever is going to potentially be working with you on this project, or the agency would be sending out, how do you make sure who those folks are, and how do you ensure they're trained in the various ways that I'm talking about? Next slide. Another thing that comes up, and I apologize, these are small, is drug supply chain and processing. So not all clinical trials, of course, involve drugs, and certainly not all clinical trials involve investigational drugs. And by investigational, I mean not approved by the FDA at all, or not approved by the FDA for a particular purpose that it's being used in a study. So you can imagine the other kind of tweak or concern that you may have to pay attention to is if you are using an investigational drug, then you need to know both the state and federal laws and the regulatory status of the drug to make sure you know that you can ship it across state lines, or how do you get it there? What pharmacy are you working with? And so we've seen for a lot of decentralized trials, they've shifted away from some of the local, investigational drug services, which are amazing resources that many of our organizations have, to using centralized pharmacies because they can dispense things across state lines and they can track things in a different way. So you can also imagine that they could create some very interesting challenges from a local point of view. If you have policies that everything has to go through your investigational drug service, how do you do that if you need to use a central pharmacy? Or how do you ramp up your investigational drug service to be able to do these other things? So you can see why, in some ways, and one of the punchlines I'll give later on is that some of the recommendations is like get a toe in the water to do a decentralized trial, get familiar with it, learn about it, and then build to a bigger one before going whole hog on something that involves, for example, an investigational drug. Especially if it's an investigator-initiated study, because I think industry sponsors tend to have a bit more resources and infrastructure behind them. The other thing you can just imagine is just logistically, sending drugs can be challenging, because how do you account for, did that person get that drug and the right person get the drug, and or do they have to sign for it? And also, what is this, how stable is that drug? How easy would that be for the person getting that drug or whatever they receive? It could be a nutritional supplement. How clear is it for them how to use that drug and to dispense and store and all that? So there can be additional training. Some of this is already there in traditional clinical trials, but you can see how it can be a big part of what you have to consider for decentralized trials. Next slide. So just a reminder about the key points about state laws. Just the state laws about telemedicine will vary. And so just make sure that you know which states will be involved when their laws are about telemedicine and shipping drugs. There may be need for physicians to be licensed in several states, or to collaborate with physicians who are licensed in other states. And then some states actually prohibit the direct shipment of investigational products to research participants. So you may need to figure that out as well. So let's shift a little bit at this point and talk about the IRB review issues. Next slide, please. So IRBs, of course, as we know, are important in reviewing and approving research studies involving human participants. And so one of the things that they need to do is, of course, make sure that the risks are minimized and the benefits maximized. So how do you do some of this, especially with the risk mitigation for decentralized clinical trials as one of the biggest issues? But let's talk a little bit about just some of the pragmatics about presenting a decentralized clinical trial to the IRB. So next slide, please. So one of the things, and this is true of pretty much any study, is like the clearer and the more information that you can provide to explain to the IRB proactively that you understand what the potential issues are and what you have already done the homework to try to address them. IRBs love that. They love to know that researchers already know what the issues are that they might have concerns about and have done something to address it, or at least explain it to make it clear to the IRB why something might not be a concern. So for decentralized clinical trials, and this is true of any study, but especially true, I think, decentralized trials, is the IRB kind of needs to know where procedures will occur and who performs them. So for example, you may even want to include a table or something like this to say whether something's going to occur in a clinic, whether something's going to be a telemedicine visit, whether something's going to be a home health care provider coming to administer an intervention, or that you're going to ask a participant to go to a local physician to get a blood draw, or a pharmacy or somewhere, get a phlebotomist to draw blood that is doing that as a service. So these are something that is really important for an IRB to know, because the IRB will be looking at each of these to say, okay, what are the risks of this happening in this way? And are these fully minimized? And then are there privacy issues, and are there engagement issues? So these are the things that from an IRB's perspective, they worry about. These, aside from the safety issues, these are the other things are not things that are usually study teams have to focus on as much as safety and privacy, but not this engagement issue. So be clear on, what procedure is happening where and who's performing it. And one of the things that I will note about in-home procedures is that they can raise mandatory reporting issues, which can happen in other research as well. But in a lot of academic institutions, faculty and staff are by state law mandatory reporters if they discover elder abuse or child abuse. And sometimes in home health care, there's just illegal or illicit behavior that becomes a notice. And so that isn't necessarily what needs to be reported, but you should have a plan and be very clear on what needs to be reported when, and that the research participants are clear about the mandatory reporting, that this will be communicated, for example, in an informed consent document. Next slide, please. This is something I touched on too, is this how you're getting the study drugs and devices to participants if you have these. So the IRB is definitely going to want to know, what technology are you using to communicate with the subject to collect data? If you're using devices, are they investigational devices to collect data? But to talk about drugs first, I should back up. And as I said, they're going to want to know who will ship the drugs, and certainly not just the IRB, your organizational. If you have an investigational drug service, there may be requirements for you to go through them. And if you're not, the IRB would need to know that you're not using that, and how that is going to work, and how you're going to make sure the right person gets the drug. And if the product's not used, how is that going to be sent back? And how is all of that going to be tracked? How are you going to control any drugs, but especially any investigational drugs? Because the FDA will really wants to make sure that that investigational drugs are accounted for and tracked. True for devices that will be used to capture study data. Are you sending them to the participants? Are you expecting them back? If you're going to expect them back, how are you going to get them back? How is data transmission secure? And so you can see another area for a consultation maybe with your informatics or IT folks. So making sure that that's HIPAA compliant, or it meets the institutional requirements for data security. So these are some of the things that can pop up with the use of decentralized or devices in decentralized trials. And you can also imagine, which we'll get to, is that it does suggest an educational or training component for not just the study team, but research participants. Next slide, please. This I alluded to in my last slide, privacy and confidentiality. So privacy is really, how do you make sure that information about people, private information about people, is either collected or discussed in situations that others aren't likely to hear, or that is only a few people can see any directly identifiable information. And confidentiality is usually means how you're keeping data secure. So as I noted, the HIPAA privacy rule is likely to apply to a clinical trial. So that's something that you'll need to make sure that that if there are any third-party vendors, for example, you might need a business associates agreement. And if you have these data being transmitted remotely, making sure it complies with your data security and your data storage requirements at your institution. So these can be a little tricky to navigate, but often increasingly institutions are like pre-vetting platforms and have standing business associate agreements that can help facilitate making some of these arrangements easier on the investigator. So next slide, please. In some ways, I think this is the most important slide for me, is that the IRB will want to know, okay, are there greater risks to research participants by doing a research study remotely? It could be that the risks are lower remotely too, but the IRB may likely take the position that there's going to be an increased risk. And the increased risk is from the idea that maybe the quality of the monitoring will not be as robust as when participants are coming in physically to a research location and seeing a physician or nurse or other healthcare provider face to face. So these will be some of the things that you would want to proactively address in any protocol or IRB application is what are the inclusion exclusion criteria and how are they going to be assessed? Will they be in person? Will they be remote? If they're remote, how do you know that they're accurate? And how do you get the information in a timely manner to make sure that you meet the windows for assessing inclusion criteria? Adverse event monitoring. So this is going to be a case where you may need to, if you're not seeing people in person, may need to be really clear with research participants about what an adverse event is, why you need to know about it, and what to do if it is an adverse event that was not expected or one that is happening at a greater frequency, or what kind of follow-up care may they need to get, and where would they need to get that? What should they look out for, and how are you making sure that they're okay? How do you educate them about how to record information that you may want? Because some of this you might be able to collect through some devices, mobile devices, but who is going to monitor, for example, if you're monitoring remotely heart rate, how often are you checking at that, and who's looking at the data, and what is your plan if you find out that somebody remotely is having an issue that needs to be addressed promptly? So making sure that you have the personnel to address that. So this is something that I think is a little trickier with decentralized trials, but is really one of the cornerstones of making sure research participants are safe. Next slide, please. This is one that I'm not going to spend too much time on because I know you got a whole session dedicated to electronic informed consent, which I think is here to stay. I think it's something, though, the reminder I'll put here is that even though it may be remote, there's still an expectation from the IRB that it will be robust, and for a clinical trial that there's going to be a conversation and that there's somebody there to answer the questions and make sure that the research participants or the representatives understand what the research entails and voluntarily agree to participate in the research. So this may be something where, although I think there's a lot of comfort with a lot of folks of using electronic approaches, you still may need to, and especially for, I think, the diversity and inclusion, and when you're approaching health equity, think about people who may not be comfortable with an electronic approach or do not have access to good internet to be able to participate in this process. So are there ways that you can actually conduct a conversation over the phone still and send people through the mail a consent form so that you can talk about it, and how do you get it back if you do it that way? And this is true that we just had a bill in our state legislature to expand our broadband access in rural Wisconsin, because there are still folks there that do not have great access to the internet, which you can see would have a significant impact not only in the informed consent but the remote trial interventions generally. So thinking through, how can you actually work with those? Is there some hybrid that you can do of in-person and remote that works well with the technology that's available? The only other thing I'll point out is that, as a lot of individuals are knowing, and I'm sure this will be covered, is that depending on whether your study is FDA regulated or not, there are limits on which platforms you can use, because not all platforms are what the FDA calls Part 11 compliant. So that's a buzzword for you. And so if you need to make sure, if you're doing an FDA regulated trial, that it's Part 11 compliant. Next slide. I will mention again, just, and I want to wrap this up so we can talk to questions. Who's engaged in human subjects research? This is something I mentioned before, that this can have an impact on who needs to be covered under an IRB approval. So you can see with home healthcare providers, for example, they could be considered engaged in doing human subjects research, but if they're not part of your organization, they may need to have some IRB cover them, and not all IRBs are willing to cover them. There's some concerns about liability issues and how you actually have responsibility. So this is something that early on, this is what you would want to discuss with whichever IRB you're using, whether it's a local IRB or a single IRB outside of your organization. So this can also affect your 1572 form. So these are just little things to think about that can have big impacts. So to wrap up, and so we can get discussion, next slide, some issues to think about, and then go on to the next slide, please. First, think about, there's great reasons to decentralize trial, but is it the right approach? Can you meet your objectives? Do you want to go whole hog, or put a little toe in the water, as I said? What works with mobile technology, and really, will this enhance your recruitment, retention, and the diversity of your subject pool? Those are things to think about in approaching that. Next slide, please. Just get a sense of what state laws and federal laws might affect for medicine, telehealth, shipment of investigational products, and electronic informed consent. Next slide. If you're budgeting for a study, this could have an impact on your budget. It may reduce some costs, but it might require increase in others, like if you need to buy technology, if you need to get new IT platforms, hire other personnel, legal consultation, pharmacy assistant, and then IRB review fees if you're using an external IRB or a central IRB. Next slide. The other thing is training and education has been a theme throughout. What do you need to train and educate participants on? If you're recording data, recognizing adverse events, how do you train them? Research sites, if it's a multi-site study, how do you make sure everybody's on the same page across all the sites? What's the data flow plan? What are the communication expectations? And again, for mobile healthcare providers, how are you making sure that they are trained, especially if they're considered engaged in human subjects research, about things like human subjects protection, good clinical practice, and making sure that the protocol is implemented in the way it's supposed to be implemented. Next slide. How will you monitor data safety? Will it be completely remote monitoring compliance? Probably. How are you going to capture the data and make sure it's of the quality you want? What are your reporting procedures for adverse events and unanticipated problems? How are you going to address safety issues? So this is something that I think needs to be thought about early on for these kinds of trials. Next slide, please. Mentioned this before, the availability and comfort with technology, not just participants, but also the study staff. But most participants or most people in the United States do have access to a smartphone. So you may have to think about, how do you adapt the technology, including a consent form, to be displayed on a smartphone as opposed to a tablet or something else. But there's a pretty high number across racial, ethnic, gender, age, and those who have access to smart devices. Just thinking about what happens if you don't have access to technology or an unexpected interruption in internet. Next slide, please. Good thing to map. I've heard somebody who has done this well said, map out everything on a whiteboard. Make sure that you're prepared to change, because you need to assess what's working and what's not working, and make those changes in real time or close to real time as possible, and work with your IRB on that. And then next slide, and then we have resources and questions. If you need to use a single IRB, which is my other thing, is that's a one IRB to review the entire study. Just make sure that you're thinking about how their approach to review of decentralized clinical trials. A lot of the independent or the commercial IRBs are quite familiar with these. They can be quite costly, but make sure that you're talking with an IRB early on. And then I have a slide with resources, and then I think we should get to discussion because I went longer than I meant to. So thank you very much. So it looks like we have some questions in chat, Sarah.
Yes, we do. Thank you so much. That was a wonderful presentation. And even from my standpoint on the ethics side, I appreciate all of your comments about the potential risks to folks that don't have internet or their ability to participate in research that is so tied to the technology. On the other side, it seems like we do have so many more opportunities for people in remote areas to be involved in research. So it is an interesting balance in moving the research forward. I think COVID put us in a situation to start using these things immediately, and they do have staying power. And I appreciate all of your comments there. We do have a question in the chat about, and I was also interested in some of the issues around what happens in the home. And I do think your idea about being ready and transparent if the person in the home notices something that's reportable. And so I might come back to that. But our question in the chat is speaking about liability issues for personnel going into the home. And would a hiring agency bear the liability? Does it belong to the research? Like, what are your thoughts about that?
I think that is a great question, and I will give you a waffly answer, because I think this varies by state, but it also means that there's also the strangeness of research. And I mean that with all due respect to research, because that's what research is, what I love and why I got involved in with this enterprise. So in the research, as we know, principal investigator is ultimately responsible for the safety and welfare of research participants. So there's going to be some element that the researchers are responsible to make sure people are trained and that nothing is untoward is occurring. Now, that's true of whether it's a home health agency or your own study team, that you can't control the actions or behaviors of everybody, but you certainly can identify and make sure that you're on top of it so that you can recognize and address that. So this is a question I would say for your legal counsel, and what would go in a contract with a home healthcare agency. Like, what are the limits and who would cover them if there was a lawsuit or some legal action? That will get tricky, and that will depend on what that relationship is from that perspective. And so you can imagine sorting out what is a research issue versus a non-research issue can be some of the hardest parts. So this is like, don't do this alone. Talk to your legal counsel. And this is something to get sorted out early on too.
Yeah. I have maybe a little bit of a different question, and I like the idea of how we're like using companies that are in the community, like different lab or phlebotomy companies, to do some of our lab draws, right? And how that works. And I'm sure that that is, a separate contract, and how those labs are like put in. That's a lot of detail there. I'm interested if you have any experience in, like, say, pediatric labs, where sometimes the research labs are drawn at the same time as a standard of care lab. And that might happen, I guess, in adult worlds too. Any thoughts about how that can be done in a remote situation? And is it any different than what we would expect on a remote lab draw otherwise?
That's a great point. And I think one of the things I really like about that is thinking through how you can piggyback research procedures onto clinical procedures is always a very good idea. And I think it wouldn't be very different. And especially like from the perspective of engagement. So one of the nice things that we have some guidance that one of the regulatory agencies has issued is said, if somebody is just doing something that they normally do as a professional service and doing it for research purposes, they're not engaged. So you can have a contract that is just speaking to, like, you are going to draw this blood for us. So it's a little different than if they then had to do a blood draw in a very different way than they normally do. Then that might verge on them becoming engaged in the research intervention and being covered in a different way. So I think it's that's one way of just being really clear, like this is something that we would normally do clinically, that they would just normally do professionally, is very different than when you have individuals who are being doing something that is very much dictated and different because of the research study, both in like manner of delivery or manner of performance, or something that you're giving the investigational drug can sometimes move people over into being research personnel.
Mhm. Do you, I have another question myself. Do you think that the different layering that's required in the remote world, do you think that adds any confusion to the participant? But
I love that question, Sarah. And as you know, we all struggle anyway between trying to make it clear to people, this is for clinical care, this is for research, which may or may not help you. And I think you're right that there could be, and we, that would make it incumbent on us to like, how do we make it clear? Like, you don't have to do these things. They're for research. These people coming in are coming in for a research purpose, but sometimes it's going to be piggyback. So just always, I think, checking in with folks to make sure that that it's very clear. And this may be something that part of the training for home healthcare personnel. So for example, they may be coming in for a clinical reason, and then maybe for research, drawing a certain amount, a vial of blood.
Mhm.
But when they are there interacting with the person, say, remember, this part is for research. Are you still okay with doing this? So that's part of that excellent, the training expectations I think you'd want for home healthcare providers, and that training in human subjects research can really help them also be aware of why they need to make a distinction when they're interacting with people who are participating in a research study.
Right. And I would also add that it seems like you could also, it's the training that's so valuable because the home health folks need to understand who they're calling for which problem. Is it a research problem or
Exactly.
is it a standard of care problem? And sometimes those questions could be a little bit confused. So I appreciate all of what you've gone over with us today. And I have a question in the chat about retention rate of participants who've joined a study with more of a decentralized focus compared to centralized studies. Do you think there has been a difference or do we know yet?
I would like to know the answer to that too, because I think that is an area where anybody who is has extra time to do a research project, it would be lovely to see. And actually, how would you measure that too? Would be great to figure that out, because I think that a lot of what we hope is this is the case. And right now, as you can imagine, we have the confounding factor of COVID, which we don't know whether we're all behaving so differently now that whatever data we have now would not be applicable in the future, or we've all changed, so we're going to all behave this way still afterwards. But so that's a long-winded answer to say, I think there's suggestions, but I tried to find some papers trying to nail this down, and I haven't seen a robust academic paper on this, and I'd like to see that. And it looks like there's some suggestions about who could do that.
Right. I'd like to close out today with one more question about e-consent with FDA studies. Do you have any thoughts about differences there or what we can do to facilitate that?
And and Jane, I love this question, and this is something near and dear to my heart. I'm working on a project with other folks at the University of Wisconsin, Madison, and one of the things we have noticed is that as people have gone to e-consent, it's essentially a translation in many of these clinical trials of what you would have put in paper into this electronic, and you have people sign electronically. And that's going to that is something that will probably comply with FDA regulations, because a lot of the platforms that people are using do comply with that Part 11. So DocuSign, for example, is one that has a Part 11 compliance, and other products have, and certainly REDCap, which is near and dear to our CTSA hearts, is able to become Part 11 compliant. There's a great paper that was just published, I think it was earlier this year or late last year, on REDCap and e-consent. But I would say that, and this is going beyond what you're asking, is I would love for this to be an opportunity for us to not just move paper into electronic, but think about how, and REDCap is a great way of doing this, of making informed consent better, leveraging what you can from an electronic environment, both in terms of having prettier presentations, more tailored approaches to individuals, graphics, and not as heavy text. I know that takes more work, but I think that's something, and the FDA certainly accepts having more creative approaches to informed consent too.
Yes, thank you so much, Dr. Cobb, for coming today. I'm going to close out our session with just one to highlight everyone. Please see the evaluation that is in the chat. Please click on that and provide us some feedback. And I want to highlight our next session in our summer series is June the 30th. That's 2 weeks at noon. We will be doing options for in-home clinical trial visits. And Dr. Akubazi, who is an assistant VP in research operations at MedStar Health, will be presenting. Thank you so much for coming, and have a good day. Thanks, Dr. Cobb.
Thanks for having me. Take care, everybody.
Thank you.